So good morning, good afternoon, good evening, everyone. If you'd like, there are closed captions that are being automatically generated. So if you just press the CC button at the bottom of your screen, you'll have those come up. There's also a Q&A box. So if you have any questions for the speakers, if you could please put them in there. And then during the second half of the webinar, it'll be a discussion and we'll answer those questions then. So my name's Sarah Bourdin, and I'm delighted to welcome you all to this second webinar in MeSH's webinar series, Strengthening Routine HIV Data, a Female Researcher's Perspective. So the aim of this series is to discover the perspective and work of brilliant women in the HIV field. And these women will discuss their contributions to strengthening the understanding, collection, analysis, and use of routine HIV data towards the aim of accelerating and tracking HIV decline in sub-Saharan Africa. So this is led by the MeSH Consortium, which is part of the London School of Hygiene and Tropical Medicine. And at the MeSH Consortium, we aim to maximize the potential of data routinely collected through HIV surveillance and service delivery platforms. Sorry about that. So please make sure to follow us on Twitter and the website for updates on the series, and also to see the recording of this webinar, because it will be recorded and uploaded onto the website. My colleague Tom will just pop those in the chat box now. And so great, thanks Tom. And yeah, so thank you all for coming, and it gives me great pleasure to introduce Ndeshi, Conteh, and Susie Welty from the University of California, San Francisco, who are going to launch us off with this great webinar. So without any further ado, I'm going to hand it over to both of you. I'll just start screen sharing now. Go.
Thank you, Sarah. It's our pleasure to be here on behalf of our team at UCSF and in Namibia. And so I think we're going to start off, obviously the content is about 16 leaks in the 95-95 Cascade, a case study for recent infection surveillance data use in Namibia. But we're going to start off a little bit sort of talking more about our perspective as female researchers and all of the things associated with that. So I'm going to hand it over to my colleague Ndeshi, who's in Namibia. Ndeshi.
Thank you, Susie, and thank you, Sarah. Good morning and good afternoon to everybody joining us. Thank you so much for taking time to come and hear about what.
Just 1 second. Can you hear me? It's not in presenter view. Yeah, I can hear you, but Sarah, it's not in presenter view yet. At least I see the.
You're on mute, Sarah.
Sorry to interrupt you, Ndeshi. I just wanted to.
Yeah, sorry, I'll try. Let me try and do that again.
No problem.
So, where is it? Let me try. Here we go. Is that good?
Yes.
Okay, perfect.
All right. So since the webinar series is looking at female researchers, we just thought that we share a little bit about who we are as female researchers. So like Susie and Sarah have introduced me earlier, my name is Ndeshi Conteh, and I am a wife, I am a mother, and my youngest son, a mother to 3 boys. And the youngest is actually 3 years old. I am also a PhD candidate at the University of KwaZulu-Natal, South Africa. And when I have some free time, which I hardly ever have, I enjoy watching crime series. And I'm very passionate about work that addresses inequity, and disparities in public health. So I think it is only natural that I love implementing recent infection surveillance in Namibia. Next slide, please. So I would also, before we start with our presentation, I think I would also want to share with everybody what it means or what my experience has been as a female researcher. And honestly, I must say that I've had very many opportunities to work with great female researchers, such as Susie. She is amazing. And I've been fortunate and blessed that I could actually do my work with other female researchers who helped me grow personally and professionally as well. But also being a female researcher who is having a spouse and having 3 kids in 3 different age categories with different needs, sometimes it is challenging to create a work-life balance. And on top of that, I am still a student. So sometimes this balance it doesn't always work out the way we had planned. Sorry about that, Sarah. I see that somebody said that they're unable to see the slides. I'm not sure if that's the case with everyone. Okay.
I'm not sure if that's the case with everyone or if it's just particular to this person. I'm trying to see where the issue is, but maybe if you tried, yeah, so if others can see it, then maybe, okay. Dr. Priya, if you tried to exit the webinar and then join it again, this worked for someone else when we had this previous issue last time. Yeah, hopefully that works.
All right. Yeah, I hope it works as well. So moving on, again, being a female researcher, especially from Southern Africa, from Namibia, and particularly my tribe, it has been also challenging sometimes navigating through gender norms because generally my culture assumes that wanting to pursue a career and wanting to have a family cannot be concurrently done. And there is generally that opinion that once you're a mother, you will have to forego any career aspirations. So we really work in an environment that is not always supportive of you being a mother or a spouse, but you also pursuing a career that you really love. So I really think that there is a great need to have female researchers to mentor and support and cheer on other researchers as well. And I've been fortunate, like I said, I've worked with many female researchers who are also mothers, who are also trying to balance the work-life situation. And there's been a support system in my journey as a female researcher, because really the road can be lonely when culturally or people around you assume that you shouldn't even be, or of the opinion that you shouldn't be really pursuing your career ambitions or academic ambitions. So over to you, Susie.
Thanks, Ndeshi. Next slide, Sarah. As Ndeshi said, or in her slide, it was written that having a supportive spouse and family and network is also a huge part. I have, like Ndeshi, have young children, 3-year-old twins, and working especially on the West Coast, where many of my calls are in the morning, and we're navigating diaper changes and breakfast and getting people out the door. It's incredibly important to have a supportive spouse to do that. And also, with international research, the challenge with traveling and whether to continue your field work when you have children is always a hard choice and hard decisions to leave your kids at home. And I was fortunate enough that my husband and children were willing travel with me to Tanzania for an extended period so I could do my work. So that pictures of us arriving at the customs hall, the old airport in Dar es Salaam a few years ago. So yeah, I guess, I just echo what Ndeshi says, that having supportive colleagues and being able to sort of just admit when you can't, you can't make a call, or when you're having to multitask on a call. I think it's great to have supportive colleagues who understand that. So next slide. Thanks for letting us share a little bit about our sort of personal experiences. Now we're going to dive into the technical. And so I guess just starting out, what is a recent infection in HIV and what do we mean? Next slide. So in this context, we mean a newly or recent acquired HIV infection as detected by a laboratory assay or method. And the duration of recent infection may vary depending on the characteristics of the recency assay that is used. For Namibia recent infection surveillance, we're considering recent as defined as one that is likely acquired within the past 12 months. And long-term infection is one that is acquired, has been for more than 1 year. Can you still hear me okay? So the rapid test for recent infection that we're using in this is a simple rapid test that results in, the results are in 20 minutes, and it measures antibody avidity. It distinguishes recent from long-term infections, and there is a need for viral load to confirm the recent infection. This is called the recent infection testing algorithm. So that is what we are using in Namibia. We are combining the Asante rapid recency test with the viral load to confirm recent infection. And then this is all rolled out as part of the TRACE initiative. And as countries move closer to reaching 95, 95, 95, in real-time monitoring of recent HIV infections will allow targeting of public health responses. The TRACE initiative is a PEPFAR supported, and it is a combination of ICAP and UCSF implementing in the countries that are on this map on the slide. And so as you can see, there is large coverage of many countries are covered through the TRACE initiative. And they're rolled out slightly differently in different countries. Some return results, some don't. Some do the testing at the facility, some do it at the lab. But generally speaking, TRACE, tracking with recency assays to control the epidemic, is in these PEPFAR countries. And the idea is that an effective epidemic control requires early detection and quick response. So we want to detect infections quickly, analyze data in real time, know who, where, and why, and then target interventions and focus quality improvement, really to get to that end of the epidemic and interrupt further transmission. So just as a sort of review, there were 1.5 million new HIV infections in 2020, the majority in sub-Saharan Africa. And you can see that the Cascade, there are gaps in engagement in HIV care among 37.7 million PLHIV in 2020. So, there are some gaps in diagnosis and ART, as well as viral suppression that we need to globally work on. And I'll hand it over to Ndeshi for the next slide.
Thank you, Susie. So Namibia is really doing well in terms of the path to attaining epidemic control. You will see that our deaths rate and incident rates are actually dropping. And as of 2021, we can see actually starting, around 2017, there has been a decline in incident cases. There has been decline in HIV-related deaths. And we are hoping that as we intensify our HTS services, we should be able to have, those lines cross, which would mean that we have attained epidemic control. Next slide, please. So with Namibia as well, we are aspiring to attain the UNAIDS 95 and 95 goals, and we are doing fairly well. Our current spectrum data as of 2020 actually suggests that 90% of people living with HIV in Namibia are diagnosed, and 98% of those are diagnosed now on ART, and 91% of those on ART are virally suppressed. So you'll see that as the cascade goes on in comparison to the 95 target, we do still have some gaps in diagnosing people living with HIV. And I think with getting the diagnosed on treatment, we're doing really well. We've exceeded the 95% target. And we also still have slightly some gaps on having the people that are on ART actually attain viral suppression. And in terms of absolute numbers or projections, we still have slightly about 20,000 people in Namibia that we need to diagnose or test for HIV, because they are living with HIV, but they probably don't know that. And in terms of treatment, we've got about 25,000 people who know they are HIV positive. They are tested and diagnosed, but they are not yet on treatment. And just about 32,000 people need to be virally suppressed. So all these numbers need to be, narrowed down just so we can accelerate epidemic control. And our data also projects that approximately 2,951 new infections occurred in Namibia in 2020. And for a small population like Namibia, I think these numbers are huge, although we say that the gap is not that wide, but when you look at the absolute numbers, we need to really intensify our services in the HIV programs countrywide. Next slide, please. So this is just the population distribution and HIV prevalence by district. Sarah, please, yeah, I needed the two maps together. So the map on the left just shows how the Namibia population is distributed throughout the country. You will see that the northern part of Namibia has the highest number of, is much more densely populated compared to the south or any other part of Namibia, but also equally, the northern part has higher HIV prevalence rates compared to other districts. You will see that the pinkish and the red districts are mostly in the north, as well as Katima Mulilo that is on the far right across the map. So I think this data just indicates that with a higher density in terms of population, that is also where we seem to get higher numbers of people living with HIV. Next slide, please. Okay, over to you.
Ndeshi set the stage. Ndeshi set the stage that Namibia is very close, and I think that's really kind of the impetus behind us thinking about how to use recent infection data, because there really is sort of this fine-tuning or fixing the leaks that needs to happen if we really are going to achieve epidemic control. I think that the big wins have been made, and now it really is focused on, we need to focus on sort of that fine-tuning and getting to the end of the race. So I think some ideas of how these data can be used. We can identify potential hotspots of recent infections, populations and geographies where more recent infections are occurring. This, caveat is that this is this is routine HIV testing data. So this also is subject to whomever is coming into facilities and attending services. but we do have, sort of some good information about among those who are HIV or testing for HIV who's recently infected. We can identify undiagnosed PL-HIV and understand why people are identifying or identified or seeking care late. So part of the RITA algorithm, oftentimes the RTRI test will be recent, but with the viral load will indicate that they had previous ARV exposure. So that's an indication of retesting, and that can help us understand who's retesting, and then also dig in a little further as to why they are retesting and why they're seeking care late. The long terms also are important in that aspect of why they're seeking care late, and something that we're interested in looking at in Namibia and working on getting those data are the CD4 counts for those that are long term, to understand how many of those are actually late stage, because we think that's also a very important category that needs to be understood better. We can identify at-risk HIV negative persons, recommend targeted control and prevention measures, and support CQI and QA efforts for system strengthening activities, including index testing and partner notification, promotion of testing, retention and care, viral suppression, promotion of PrEP and prevention activities to fix the leaks in the cascade. And one note with index testing and partner notification, I think that is something that is really important towards getting to the end of the epidemic, but also needs to be weighed against community concerns and individual, understanding of the complexities of partner notification and what that means for interpersonal relationships and violence in particular. And Ndeshi and I are also working on a study in Namibia looking at whether index partner testing and recency are, put people at higher risk for intimate partner violence in HIV testing. So we're really interested in understanding if there are negative effects of these routine systems that we're putting in place. Next slide. So yeah, recent infection testing as a tool in epidemic control, and in thinking about finding and fixing the leaks in the cascade and when each part of the cascade. So prevention, of course, we want to know why are new infections occurring, under what circumstances, are negative partners on PrEP, what does the data say about ongoing transmission, where and among whom, diagnosis, where are new infections coming from, among whom, are partners aware of their status, why are people retesting, is index testing being done with fidelity and with care, why are people being diagnosed late, are we finding people with advanced HIV disease, and then in care and treatment, are positive partners on ART, are positive partners retained in care, why are people defaulting on treatment, how do we better retain people in care, and for viral suppression, are positive partners virally suppressed if already on treatment. So these are really the things that we think we need to, interrogate the data and understand, and then put in CQI, QI activities, quality improvement activities that really focus on addressing the barriers to any of these, and really thinking more hyper locally and thinking, site level interventions, knowing that populations and catchment areas are different, and different sites, different districts have different challenges and different demographics. Next slide. Go ahead, Ndeshi.
Sorry, I didn't unmute. So recent infection surveillance has been rolled out since July 2019, and to date, we've had just a little bit about 6,900 clients who consented to RTRI, which is rapid test for recent infection. Generally, we have a very good acceptance rate when we offer recency testing to newly diagnosed positives. I think the last time I checked our data, we were at 96%. And among the clients who consented and RTRI was performed, we've had 143 confirmed recent, meaning that there has been a viral load test done to confirm that indeed they've been recently infected, and the rest of them actually are long-term. So they have acquired HIV longer than 12 months. So, and this data really does highlight the fact that we are probably reaching some people, or majority of new positives linked with testing services. And I think that is just part of what Susie was highlighting earlier, that we could really look at recency data to understand the demographics of those who are testing recent, but also testing long-term. And I'm particularly also interested in looking at whether our long-term patients actually do have advanced HIV disease. I think that would be great to just know. So our overall proportion recent is 2%. And we have females testing more recent than males. So females are at 2.5% versus 1% for men. So this is double. So, and I think this is not strange in the HIV epidemic. Gender does play a role in how the pandemic spreads, and other issues or public health issues that are influenced by gender issues. So also in Namibia, the age groups 20 to 24, 25 to 29 years have a higher proportion recent than other age groups, and the highest proportion recent is coming from the age group 20 to 24. So the recency data then is suggesting that there must be something, the pipe is probably leaking the heaviest among these age groups. And because if we've got a high proportion recent among this age group, it means that we've got young people that were negative for a period of time, but now they seem to be picking up HIV infections somewhere amongst, the pipe. So, and then 25 to 29 is the next highest proportion recent, 2.4%. Next slide, please. So currently, recency coverage in Namibia is in all 14 regions, but we haven't been in all health facilities that are providing ART, and neither were we in all districts in Namibia. I believe we have 25 districts in Namibia. However, there is now plans to accelerate recency scale up, and we plan that by September 2022, we will be much more saturated in all districts in Namibia, and we will be in more health facilities than when we initially started recency rollout in 2019. And I think this is an important move, just so that the country can get much more data, representative data, that we can look at the different trends and the different complexities in different regions in Namibia, because Namibia is such a big country with a small population, but also really, really diverse and very different. So it will be great to see what these differences are in the context of new HIV infections across the country. Next slide, please. So I want to present to you a case study that we conducted during February 2020, where we use recency data to investigate, and as part of actually the data use aspect for recency data. Next slide. So in 20, I've mentioned earlier that recent infection surveillance in Namibia has been operational since July 2019. And we during the period of July 2019 to February 2020, we had only rolled out in 5 districts in only 42 sites. Currently, we are in 122 ART sites. And at that time, we had 1,708 new diagnoses and 1,640 of those consented to recency, which is a good number. And we had, out of the number of patients that were tested for recency or recent surveillance infection, we had 3.5% of them testing recent, and that is a high proportion of recent cases. So at that time, we thought that, or we were confident that we had now enough data or available data, so we can pilot cluster investigation and response to really look at where these new infections are, what are some of the risk factors, how are they followed up throughout the cascades. And yeah, so we piloted into 2 health facilities. Next slide. So when the piloting was conducted, we used a 4-step process to actually systematically plan for this pilot cluster. And the first step was to identify the suspected clusters, and this involved looking at the data that the health facilities were reporting, and facilities that were reporting a higher number of new positives than their routine program data, would report, were of course flagged as suspected clusters, and then after that, the clusters were confirmed. So the team really looked at whether, these numbers were not just data error issues or data quality issues. Are they true clusters? Did facilities actually detect more numbers of new positives as they are reporting? So once that was confirmed, of course, and then a team was tasked to respond to we prioritize the clusters. So we prioritize the health facilities reporting a higher number of new positives in terms of like highest number. So would list the health facilities with the highest number to be top priority for investigation. And we had a team from the Ministry of Health and Social Services at national level, as well as the regional team people and the site staff. And of course, UCSF Global Program provided technical support to this response and investigation. So we went to the regions where the 2 health facilities were, or where we had suspected clusters, and then conducted the investigation. So we had an exported case list of recency clients because we have a database where our recency data is reported into. So we had the pre-exported case list of recency clients, and we, of course, prepared with the sites beforehand, before the team went to the sites to actually go through this data, so that they can prepare the patient care booklets and they have all the information ready that way to just save time to implement this activity. And we went to the site and we reviewed the index partner testing registers. We reviewed the ART patient charts. We recorded outcomes, testing outcomes, linkage to care outcomes, and then we would do. We had the team calculate cluster response indicators. So there were a couple of indicators that are aligned to the entire cascade that we were working on and making calculations on. So we just see how well our newly diagnosed people are getting services and are followed up in such a manner that it actually supports efforts to accelerate epidemic control. And of course, we use that data. After looking at the data and analyzing it, we made recommendations about program response, and we presented this to the Ministry of Health, which was actually a very great exercise, because we had the leadership of the Ministry of Health hearing, about what the findings were when the cluster response was implemented. So the final step included documentation and communicating of the outcome of the investigation. Like I said, we presented these findings to the sites, to the regional teams, but also to the national level. And we have a report that is available. And we actually, UCSF supported the Ministry of Health develop an SOP to conduct this piloting of these clusters. And yes, we had Andrew on this webinar. Thank you so much, Andrew. He was a big part of this process, this initial process. And I'm just glad that Andrew, you could join in on this series as we share part of the work that you supported. Next slide, please. So we, like I said earlier, we reviewed index testing registers for patients. We also reviewed a patient care booklet of our recency clients. And we had a form that was already in the ODK in a tablet. We inputted the data electronically, and this data is pushed up to our server, and we have a database, and so we could access the data electronically. I think this was really great because data was available much more quickly, and instead of doing this whole process manually, we were fortunate enough to have an electronic method to collect the data. So we've had various health facility staff helping with this process, where we've got different staff having the tablet, and some are entering, data from the patient care booklet, and some are entering index testing register information as they are available. And then UCSF later looked at this information collectively, just so we can interpret the information. Next slide, please. That is a picture of the team that supported us in the field. So we have got the site ART nurse. So she really played a role in getting the patient care booklets ready. And then we had the colleagues from the Ministry of Health head office, and also had the TC field officer. So this is the officer that works for the organization that is primarily responsible for tracing defaulters, for even implementing IPT as well. All right, next slide. So these are the results, and I will rush through the presentation just in respect for time. We can see that with the new diagnoses that we're following up, which are 80, as we move through the cascade, we can see some gaps and some patients falling out in between. You can see that, and I would like to highlight, for example, the testing of index partners that were named by newly diagnosed patients. So we've got about 30% of partners that were eligible for HIV testing that were not tested. So we have them not knowing their status, and they are high risk people living with HIV because they are partners of newly diagnosed people. Also, I'd like to highlight the gap in PrEP. So only 17%. So out of those, the 30 partners who tested negative, only 5 were linked to PrEP. So we can see that there is, that is a big missed opportunity for PrEP initiation and rollout there. Next slide. Also, between the two health facilities, we saw that one facility had a very good IPT rate, so they were doing very well with testing partners, but they had a lower yield, 5%, which could indicate that maybe the clients were naming the wrong partners and actually leaving out the other partners who could be HIV positive, but also look at facility B. So facility B doesn't have the greatest rate of IPT implementation, but look at the yield, about 52%. So, and that was very, very interesting, because we could be missing undiagnosed HIV people, especially in facility B. And one can only imagine if the IPT, the rate of, if only we could up the proportion or the number of partners tested for HIV, we probably would have a higher positivity yield among index partners. Next slide, please. Again, this cascade just highlights the gaps that are associated with the rollout of PrEP. So we see that a lot of the partners that are named actually do test HIV negative, and only a very handful of those are initiated on PrEP. So that means that our pipe will continue to leak, because we've got a significant amount of people who are undiagnosed and are partners of positive people, but they probably don't know that they are positive, and they may continue to be engaged in high risk sexual behavior. So I think in the context of this pilot investigation, intensifying PrEP rollout comes out as very critical. Next slide, please. Also, another observation that we made with this data when we did the pilot cluster investigation is the defaulting of newly initiated people. So Namibia is doing the test and treat, and I think we are doing fairly well with initiating new diagnoses the same day, newly diagnosed people the same day. But you can see that, for example, in health facility B, about 35% of newly initiated patients do default on treatment 3 to 6 months after initiation, and that is not very different from health facility A. Therefore, I think the data also then suggests that we need to really intensify support to newly diagnosed patients so that they can be into care, because if they do default into 3 to 6 months, we can expect a significant amount of patients, newly diagnosed patients, not to have their viral load suppressed as optimally as we'd like to, and that also again causes the pipe to leak further. Next slide. Also, facility B had very interesting dynamics of having almost 50% of their patients who are receiving ART facilities or new diagnoses are residing in Namibia and Angola. So this facility B is in a region that is bordering Angola. And this has brought some complexities in terms of recent infection diagnosis, default rates, as well as IPT, because it looks like our Namibian patients who are primarily residing in Namibia and Angola have partners between both countries, and that has posed a challenge with tracing their partners and testing them and putting them on treatment. Next slide, please. So we've had some discussions with the healthcare workers when we did the cluster investigation, and they've really highlighted, one of the key highlights that they've brought to our attention is the issue of low PrEP enrollment, and that is really supported by the data. And part of what they actually want is, the translation of PrEP information into local languages, because currently it's just in English, and that's on the prevention side. And I think when it comes to diagnosis, the issue of having partners residing in both countries and the inability of tracing partners who live outside the Namibian borders have posed a challenge to intensifying and strengthening index partner testing in these facilities. And in terms of care and treatment, the healthcare workers have reported that they've observed a low retention among adolescents on ART. And remember, in my earlier slides, I said that we've got a higher number of young people testing more recent. So that means that population group needs targeted, not only testing intervention, but also treatment. And definitely, again, with viral load suppression, they've highlighted the issue of increasing viral load among adolescents on second line. So we have adolescents that are acquiring HIV recently, but they are also struggling with viral load suppression. And as a matter of fact, they are even struggling to even stay adherent on second line treatment. And that does impact how well we control the epidemic. Next slide. So with all these challenges that I've spoken before, I think there is still opportunities for improved service delivery, just so we can stop the pipe from leaking, and definitely PrEP rollout needs to be improved. And then adherence support for newly diagnosed clients, especially within the first 6 months, is very important. And probably our approach to IPT also requires more strengthening. We've got the majority of clients naming partners who are negative, meaning that there has to be a partner somewhere that is positive that is not named. And then definitely strengthening cross-border partnership with the Ministry of Health Angola would be really great, because so that we can better trace defaulters as well as test partners of newly diagnosed positives. Next slide. I just want to acknowledge again the support of other partners who have worked with UCSF and the Ministry of Health on the recency study in Namibia, and CDC through PEPFAR, of course, has provided not just the financial resources, but they've also provided technical assistance, as well as the Namibia Institute for Pathology has supported the testing aspect of the study. We've had ITEC and ICAP also support the recency study in Namibia.
Great. Is that good? Great. Yeah, so thank you so much for that presentation. I've just stopped sharing the slides now. Yeah, thank you so much for such an interesting talk, and also, reminding us of the importance of using correct data and correct surveillance data in order to reach the UNAIDS targets in ways in which we can try and cover those gaps. So that was really interesting and relevant to a lot of people's work, I think, which is why there's been a lot of questions in the chat box. And thank you, Susie, for answering those. But yeah, I really enjoyed the talk. You're both great speakers, and the slides looked great as well. So now we have a few minutes left. So I'd like to pass on to the Q&A. And I want to make it as interactive as possible. So I see already there's been many questions in the chat box. So if you have any more, just add it in there. I'll make sure to save all of the Q&A questions and answers, and to put them somewhere with the video recording of the webinar that'll be uploaded, so that you can have a look through the questions and the answers from there. You can also just raise your hand and I'll give you the floor to ask your question if that's something you'd like to do. So I'm just gonna start off with a quick question of my own. I know, so basically we're currently planning a qualitative approach to gain insights into recency testing that we're going to do in Zimbabwe and Malawi at MeSH. And I was wondering if there's maybe a critical question you would suggest in order to gain insights among clients and healthcare workers, and what you were, if you had any recommendations or like lessons from your studies.
Yeah, I guess my first recommendation is that ITEC and CDC, and with our support as well, did a qualitative assessment in Malawi among healthcare workers about recent infection testing, and those results are available. Generally speaking, providers you know, accepted, and I think the MeSH consortium also did a similar study in Kenya, and the providers generally accept recency testing. I think there's split views on returning results. Some providers feel that it's very difficult for them to request, you know, the extra sample and to you know, do the whole process and then not promise a return of results. Others feel like they're not sure how to interpret the results. So I think there are questions around return of results and how providers feel about that. Other things that I think, you know, clients, in what we've seen, clients are accepting, like Ndeshi said, we have very high acceptance rate for consenting in all of our countries. Very few people decline, and when they do, it's, you know, lack of time, or some also report that they don't actually see the value in it, which is fair. So I think those, you know, we feel acceptance is pretty high. You know, in terms of the time it takes, I think that's something that providers are concerned about, and is something that needs to be evaluated. And then, yeah, I think how they can find it useful in their own work. And also, you know, I think we've been talking a lot about the recent infections, but I think we also want to remember the long-term infections and understand that they are, let's call it, in a failure analysis world, let's call it a failure of the HIV testing program. That they came late, and so what are the challenges and barriers that they experience? I think helping providers think about how else they can use these data, and making sure that they have access to the data themselves. Ndeshi, do you have anything else to add? Unmute.
Thanks, Susie. I think you covered it, and I think the emphasis has been more on recent infections. And I think as I look at the recency data in Namibia, I think there is a need to look at the long term. So are they, why are they, why are we accessing them late? Is it an issue of service provision? Is it an issue of the people just not accessing the services on time, and what are the barriers? So I think I'll be particularly also interested, on top of what Susie has highlighted, on what is going on with those that are testing long-term. I mean, we've got the huge majority of clients, of new positives testing long-term, and I think that should count for something, and countries should, if we are to close the leak, we need to understand also who is testing late, because they are at risk of advanced HIV disease. And looking at the data in sub-Saharan Africa as well, we've got a higher proportion of people actually not being diagnosed with advanced HIV disease, and that has negative outcomes on, you know, when they start ART. Yeah.
Great, thanks. That was very interesting to get your insight on that. I'm just going to ask, I think, one last question, and this one's from Paul Mee. So he says, you mentioned targeting interventions for adolescents. Do you have any thoughts on who these can be implemented in practice, on how these could be implemented in practice in the Namibian program? And any thoughts on whether there could be targeted interventions for men to improve male engagement and retention in care?
Do you want to take the adolescent part, Susie? And I could maybe speak a little bit more on the male engagement.
Yeah, I mean, I think kind of our take home from this and from the focus group discussions is that, you know, even in sub-Saharan, even in subnational units, which are relatively large, there are differences in what interventions work. We heard about some, you know, interventions that work for retention in some of the sites, and others that they were using for others. So I think to us, I think the take home really is that QI needs to happen, and the sort of like quality improvement lens really needs to happen at the site level, with an understanding from the providers, because they know their catchment areas best. They know who's coming in and testing and what their risk factors are. So I think making sure that the prevention programs are informed locally by the facilities and implemented by, you know, the districts, and is most important. And I don't have any suggestions on specific, you know, there's a lot of AGYW programs, and I think a lot of those are successful, but I don't have any other specifics. Ndeshi, do you?
Yeah, and I think with adolescents, again, there are multiple projects, like Susie said, that are supporting adolescents. But if we still continue to get a higher proportion of them testing resistant, then we probably have to zoom in and still evaluate whether our interventions are yielding the intended results, because clearly we are getting a significant number of young people testing newly positive, you know, young people that we worked hard to keep negative are now testing positive. So there must be something that is leaking. And I think recency data can help us start to understand that, because now we can particularly go to the adolescents and engage them and find out why this is the case. So regarding the men, yeah, they are a special population, and I think Namibia has been implementing various men engagement programs so they can just improve, you know, improve on how men actually access services. And I know one of the studies that was implemented in Namibia for improving testing rates for men actually shows that men generally prefer to access their services in an environment where it's dominated by men. I mean, they don't want to go to clinics because they take long, they don't want to be in queues. And clearly, when we look at the recency data with men testing less recent than females, we could deduce that no more majority of men are testing long-term, meaning we are reaching them late with an HIV test compared to women. And you know, that can also be embedded in health-seeking behavior of men. However, we still need to find ways to get them on board. I don't think any country has completely gotten the, you know, the magic portion to engage men, but we need to continue trying. But as I look at recency data, I'm just wondering, because the majority of men that are testing long-term are actually older men, and I'm just beginning to wonder, is there a link between older men testing long-term and young women testing recent? You know, issues of transgenerational sex, and you know, so you know, and this is the interesting thing about recency data. It can help us again understand our epidemic. So I'm hoping that as we are getting more recency data, we can try to make links between different age groups or different genders in how their recency rates contribute to the other. Yeah.
Great, thank you for that. And also on the subject of men within HIV care and engaging in HIV care, our fourth webinar, which is happening end of October, will be led by Morna Cornell, and she'll be discussing the issue of including men within how we think about like HIV data and HIV care and policy. So yeah, if that's something you're interested in, make sure to be there for the fourth webinar. So I think that brings us to the end. We're a bit over time, so thank you to everyone who stayed, and thank you for everyone who joined, and I hope that you all enjoyed. The recording will be up on the website shortly, probably next week. So yeah, just keep an eye out for that. We have, so Tom in the beginning put our Twitter and website links in the chat. So if you want to have a look on there and keep up to date and, you know, share the recording and discuss amongst yourselves. Our third webinar will be happening on the 13th of October at the same time, so 12 to 1 p.m. UK time, and it'll be presented by Dr. Malebogo Tiliane from LSHTM, part of the Alpha Network, and Julie Ambia from the University of Nairobi, Kenya. and information for that webinar will be up on the website next week. So thank you so much again, Ndeshi and Susie. It was really a great presentation, and there were a lot of good discussions. I'm really happy about that. So yeah, thank you again, and thank you to everyone who joined. Have a lovely rest of your days.
Thank
Bye.
you. Bye, everyone.